In this recording, we will discuss the problem audiogram and the role of the professional supervisor. The employer is responsible for establishing and maintaining an effective audiometric monitoring program, and the occupational hearing conservationist and professional supervisor are responsible for understanding the audiogram and following up on the findings. Regulation agencies, such as OSHA, identify which tasks may be performed by the OHC and specify that professional supervisors have oversight of the audiometric portion of the hearing conservation program. The Council for Accreditation in Occupational Hearing Conservation, also known as CAOC, recognizes the benefits of a qualified professional to a hearing conservation program and has created a certification for the professional supervisor. A critical responsibility of the professional supervisor is to review problem audiograms. In this recording, we will discuss problem audiograms, including standard threshold shift. We will also discuss the responsibilities of the professional supervisor. Topics included in this recording are the problem audiogram, standard threshold shift, medical referral, and the professional supervisor. It is usually the responsibility of the OHC, Occupational Hearing Conservationist, to determine the basic validity of the audiogram. The preamble to the 1983 Occupational Safety and Health Administration OSHA regulation states that technicians are permitted a preliminary look at audiograms and that they must refer problem audiograms or audiograms with questionable validity to a professional reviewer for further evaluation. There is no single published exhaustive list of problem audiograms. However, the OHC and the professional supervisor can develop their own criteria. The following examples can be used when considering the criteria for problem audiograms. All workers with a problem audiogram are not required by regulation to be examined by an audiologist or physician. In some cases, specific follow-up action is required by a regulation. The PS, or the professional supervisor, is always obligated to make referrals and recommendations in compliance with regulatory stipulations, but also keep the best interest of the worker in mind in terms of managing the hearing health condition. STS, or standard threshold shift, is likely the most common of the problem audiograms. STS is the degree of hearing change sufficient to trigger mandatory employer intervention. OHCs must know how to calculate STS. OSHA, MSHA, the DOD, and FRA all define STS as an average shift from a baseline of 10 dB or more at 2, 3, and 4,000 hertz in either ear. An aging allowance is permitted but not required by federal legislation. It is the OHC's responsibility to calculate STS. To calculate STS, the current thresholds are compared with the baseline reference for each ear. The baseline audiogram is the reference for the comparison of all future monitoring. The baseline must be done within the first 6 months of a worker's first exposure at or above the action level, which is the time-weighted exposure at which employers must institute a hearing conservation program. The STS calculation compares the threshold values at 2, 3, and 4,000 Hertz between the current and baseline audiograms and computes the average difference between the tests. An STS is present if the average difference between the two audiograms is 10 dB or more. However, if the hearing has improved between the baseline and the annual audiogram, then the improvement between the two thresholds is calculated in the same manner, but uses a negative number to reflect a change for the better. Age corrections are permitted but not required. This is based on the theory that because the worker grew older between the baseline and annual audiograms, a portion of the hearing was lost due to the natural aging process or presbycusis. Most employers use age corrections as allowed because it reduces the number of STS occurrences. To calculate an age-adjusted STS, the OHC must know the worker's sex and date of birth. Regulations show median hearing threshold levels by age for men and women, which are referenced when calculating age-adjusted STS. However, there are numerous reasons why not to use age corrections. For example, the age correction values proposed by NIOSH in 1972 were derived from a relatively small number of workers, about 300 non-noise exposed and 792 noise exposed, whose hearing was tested in 1968 to 1971. These values are based on median data for groups of people from cross sections of the population rather than from a longitudinal data set. In addition, applying the average hearing change for a large population to an individual worker is problematic because the aging effect is overestimated for some people and underestimated for others. There is no way to predict which workers will have less or more age effect. Age corrections can delay identification of noise-induced hearing loss because the age factor can mask the degree of hearing decreases. In other words, a significant hearing change may not be identified before it's too late to prevent a permanent hearing loss. For these reasons and more, OSHA programs in Oregon and Washington do not allow an adjustment for presbycusis when calculating STS. An OHC can use several sets of criteria developed by different professional organizations to assist them in determining when to refer. Among the most widely accepted is the otological referral criteria for occupational hearing conservation programs, developed by the American Academy of Otolaryngology, Head and Neck Surgery. These criteria are meant to identify larger changes in hearing or abnormal conditions that are likely to be significant medically and/or in terms of communication difficulties. The AAO-HNS recommends medical referral on the basis of the baseline and periodic audiogram. When applying these criteria to changes in hearing, the original baseline should always be kept to compare with the current audiogram. This practice introduces another concept to the audiometric baseline, that is a medical baseline. A medical baseline is used when a decision is made regarding medical referral. It is often the same as the baseline reference for identifying STS. The PS should track the medical baseline separately from the audiometric baseline. In any case, The professional referral should be made if the audiometric results or history reveal these circumstances. Regulators use the term professional supervisor or professional reviewer to refer to an audiologist or physician who oversees an audiometric technician and has exclusive authority to revise baseline. KAOC defined a scope of practice for PSs and developed a credentialing program for qualified audiologists or physicians with experience and expertise in hearing conservation. The role of the PS is based on regulatory requirements, as well as a best practice approach to hearing loss prevention. So to summarize, audiometric monitoring information must be reviewed and problem audiograms identified so that the OHC, PS, employer, and worker can all try to prevent a potentially life-changing occurrence, such as permanent hearing loss and or tinnitus. Take care.